All right. Today in 827, I'm going to be lecturing on the acute care environment. Um, and so you can see here that I have quite a few readings and handouts posted um, that I've gotten specifically from your OT and acute care textbook. Um, I'm quite passionate about this book. My time in acute care was a time that was a little intimidating, just with how sick people were. And it was really difficult for me to learn how to manage my time going from room to patient room to patient room. Um, and then, you'd go to a patient's room and then they'd say, "Oh, Days of Our Lives is on. Can you come back later?" And then you'd go to another room and then their doctor would be in there and you couldn't interrupt the doctor. And then you'd go to the other room and Tavia or Krista, the nurse with the mustache, would yell at you and say, "Get out, we're doing nursing cares. Come back later." Right. And so then I felt like in acute care, I was constantly spinning my wheels, and it was very busy, very fast paced. That said, I also really felt like as an OT, I had the biggest bang for my buck, meaning um, my expertise and my evaluations that I did with patients and my treatments that I did with patients were the things that really informed that next step or that next level where that patient was to go to upon discharge. And so, um, although it was intimidating when I first started, I think I did acute care in my level 2 field work. And then I transitioned into my first full-time job with wasn't just acute care, it was acute care, transitional care, a bunch of different things all in once. But I found myself really enjoying that acute care setting and sort of being the first person to volunteer. Hey, I'll go up to acute care because I really enjoyed it. So please, 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 take a look at all of these resources. There's very, very good tidbits that I wish I had. We didn't have a textbooks geared towards acute care back in the day, and it. So when I reviewed this book, it was like so enlightening to me. I just felt like, oh my goodness, this would be so helpful for anybody doing anything in acute care. There's so many really helpful techniques and tips. And there's even a USB connection in your textbook that has really good video demonstrations of intervention sessions, and just to give you a better picture of what these settings of acute care ICU, what they look like. I think your lecture with tubes and lines and all of those things, a lot of your clients will be having tubes and lines in acute care in ICU. And so it should hopefully go really well together, this kind of information. So I'm going to go ahead, I'm going to stop sharing the resources and such here, and I'm going to open up my PowerPoint. Okay, so in the acute care setting, I hope that you can identify some common conditions that we see in acute care. I'll be talking about some different types of diagnoses that we commonly see in acute care. I hope that you'll understand your role in as OT. What is our main objective in acute care? I do have, or your textbook, your readings has a sample acute care evaluation. And so I'd like to have some kind of in-class activity or simulation that I'll post to Canvas so that you can get some experience, at least doing some evaluation techniques and what you would evaluate, how you would evaluate that in an acute care setting. Students will gain and appreciate the critically ill patient in ICU. So I do talk about some of those tubes and lines, um, which ones are invasive, which ones are non-invasive. I certainly have some stories about some of them. And some of them I have never worked with before. Our hospital didn't have the capability of having some of those. So some of these are even new for me. And then just looking at appropriate evaluation methods for ICU. Okay, so we'll be talking about all those different areas. So brief history, how does OT end up in acute care anyways? And so this might be some review for you, but OT began way back with the moral treatment movement, right? Where all people deserved to be treated well, or morally. Certainly as an OT, we advocate to our patients who have disabilities, right? And even though people may be different, people may have disabilities, they still deserve the best quality care that we can give them, right? And so that's where people with mental illnesses were brought to hospitals, brought to facilities, and they needed to be treated morally, right? And OTs were really sort of on the cutting edge of that. So after that moral treatment movement came arts and crafts movement. The arts and crafts movement really brought in activity, right? Really explored people's interests. And the whole idea was, well, keep people busy. Again, we're in mental health units, right? Keep the minds busy, and then the hands will get into trouble, right? And so just kind of keep the mind off of things, keep the mind off the depression, keep the mind off the suicidal thoughts, um, and keep them onto other things like activities, hobbies, those kinds of things, and will help. Um, Eventually, we bumped into World War One. World War One is when we really started working with soldiers, and we started working with soldiers not just in the mental health unit, but also started to go into maybe some vocational training. How could we teach wounded veterans how to get back to work? Okay. Um, we would do like the bilateral sander, woodworking projects, those kinds of things, copper tooling. A lot of those things you still see as treatment modalities or therapeutic activities that we see in maybe mental health units. Uh, and they came all the way back from World War One in an effort to try and help train our wounded veterans or our veterans coming back from war to do more industrial types of things because it was the Industrial Revolution at that time. This is where we really started looking at, well, what job is the veteran going to go and work on? And then let's break up that job so we can identify exactly what motion we need to strengthen. So that's sort of where we started really tying in that activity analysis of um, what are the performance components? What are the different types of tasks that are needed to make up this occupation? And so we can kind of work on some of those smaller steps, smaller things, and then build towards getting that person back to work. During that time, there also was the TB epidemic, polio. And so we had a very prominent medical community where these particular people with these diagnoses were just saturating our hospitals. Um, and they actually were viewed as um, burdens on society because they couldn't contribute to society, they couldn't work. And so we're starting to see people more with disabilities and where do they go? OT was brought in again with that activity analysis. Were there things that we could do or recommend or help so they could eventually work in that industrial revolution time and contribute to society? And then World War II came about. And so then um, we really started working with wounded veterans again. And this is where we sort of expanded into orthopedics. So in World War II, we were working with a lot of veterans who came back maybe with a traumatic amputation, um, those kinds of things. So we got into orthopedics. Um, we looked at maybe adapting different things, activities that they could do, so they could dress themselves, and again, so they could get back to work. And so we really saw OT sort of step up with orthotics, prosthetics, and general rehabilitation during that World War II time. I believe this is where we really also started seeing an increase in survival rates because historically speaking, there was all this scientific advances with medicine, right? And people were starting to live longer. People were starting to be cured of certain types of diseases. So all of this is sort of going on at the same time, right? And then that rehab movement began. And so that's where OTs were really looking at adding exercise, therapeutic exercise. We need to make somebody stronger so they have the strength to do their self care routine. We need to make somebody stronger so they can go back to work again. So OTs were vital in vocational rehab, as well. Again, kind of retraining that person to go back to work, and rehabilitating them to a prior level of function. So you can kind of see that's where then different practice settings branched off. So in rehab, right, we have rehab hospitals, we have acute care hospitals, and we're trying to rehabilitate patients with certain conditions to get back to their prior level of function. And so that's where we have these offshoots of different OT practice settings. Now, with the rehab movement, you'll kind of notice we may have globbed on a little bit to what nursing practice was doing, right? What physical therapy was doing. And we sort of globbed onto what some of those people were doing too. Again, an effort to help people get back to the things that they once used to get back to. And so that again led to sort of that crisis, right? And a crisis with reimbursement, meaning um, if I'm an insurance reviewer and I'm looking at a treatment plan of a physical therapist who is stretching out somebody's shoulder, doing passive range of motion, right, to try and maintain or try and increase or improve their shoulder range of motion. And then I'm looking at an occupational therapist plan of care, and they're doing the same treatment as an insurance company. Why would I be paying for two disciplines to do the same exact thing? And so that's where we needed to communicate a little bit more. We needed to provide more evidence into the justification of why we were doing what we were doing and why were we skilled, right? What was it that held us apart from other disciplines? Excuse me. So that's where we really have tried to use or unify our profession, why we use certain terminology, why we bring back occupation. And so in acute care, you'll notice we might not necessarily focus on range of motion, but we might focus on getting that using range of motion to get that person back to where they used to be functional or functioning. So long history, right? Long history that sort of lent its way into why OTs belong in acute care. So I have a slide in here, evidence-based practice. And so I feel like in acute care, um, evidence-based practice is something we need to be thinking about. But I will say that I was guilty in acute care. We sometimes focus on or become hyper-focused and vigilant on what it is that we have to do, and we don't have a lot of time to do it in, right? Acute care is usually just a bump in the road or a stop in the road. And so I feel like in acute care, evidence-based practice doesn't always happen right away. Okay. Or it doesn't always happen. And so It's important because it's that conscientious, and I got this in the way here. See here, it's a conscientious, explicit, and judicious use of current, best evident decisions about the care of individual patients. And so we not only have to know what is in the evidence as far as what's the best way to treat a condition or a client with a specific condition, but we also have to integrate our own clinical expertise with what evidence is available. And then we have to decide, does this apply? And so evidence-based practice isn't just looking at a research article and saying, okay, this is what's in the research article, this is what I'm going to do. But it takes that application of what you read in that research article. Does that apply? And is that the best decision you can make for your client that is in front of you? So by having evidence-based practice, it ensures better quality, right? Because you're applying perhaps what you're noticing in the evidence. It validates us as a profession. And so I just showed you that historical slide, right? Where sometimes we're viewed as encroaching on PT, right? Or what makes us different than nursing, right? When we're looking at getting somebody dressed in the morning. Well, nursing can get somebody dressed. What's the difference between them and us? Okay. And so this evidence-based practice then should validate us as a profession. We can use evidence-based practice as a framework because it incorporates our clients' values and their preferences, right? And so we're finding out individually what our client needs, what they want, right? What they prefer. We're using our clinical expertise. We know how to transfer somebody out of bed. We know how to transfer somebody into a wheelchair. We know how to transfer somebody into the bathroom. Okay. We have information from a practice context, so clinical setting, right? We're in acute care. We know they're sick. They may have weight-bearing precautions. And so then what does research show that's the best way on training somebody about bathroom transfers, right? Or becoming independent with toileting or completing a shower safely and independently. And so evidence-based practice has us take a look at and to consider all of these things. So the challenges, right, in acute care, I mentioned, and I may be a little biased here relating on personal experience, but in acute care, I didn't have a whole heck of a lot of time to be doing systematic research article finds and reading research articles, okay? I had to do a lot of that on my own time. The good part about it is the more you do on your own time, right, the more you learn and the more you know what is in the evidence. And so it may be time consuming right away, but over time, right, it doesn't seem to take as much time. So, starting out in field work, right, I was super overwhelmed with acute care, right, or super overwhelmed with trying to explore, trying to read, trying to understand research articles from that acute care perspective. And I didn't find a lot right away. There's a lot more now, right? Sometimes I had to search for diagnoses. Sometimes I had to search for settings. Sometimes I had to search for other conditions that were like the condition I was working with. So that was a challenge, right? It also was a challenge if I didn't have a lot of clinical expertise. How could I draw upon that? And so that was a challenge, right? The more experience I got in acute care, working with really ill patients, I was able to increase my confidence over time because I had seen things before, right? And so that was a challenge at first. So what are some solutions that we can come up with about implementing or utilizing evidence-based practice, or some things that I can think of off the top of my head? Was one, giving yourself a little bit of grace and knowing that it is fast paced, right? And it is hard to be productive at first. And so to cut yourself a little bit of grace with that and to expect that, okay? Another solution or recommendation I might have is to set aside some time in your day and just devote yourself for looking at systematic reviews. Okay, this might have to happen again outside of work time, but again, this is for your career and this is going to make you a much better practitioner um, if you're up to date with what evidence is out there. I think since time is difficult, what we sometimes did in our hospital or in our clinic is we would sometimes divide and conquer, right? And so in the hospital where I worked, we had 3 OTRs. We had way more PTs than that. But we would sometimes have a meeting, right? And we would share an article and we would share what we learned from that article. And we would sort of discuss or problem solve. Hey, what are some things that we can implement from this article? That we could incorporate into our treatment for PT or that we could incorporate into our treatment for OT. And that really was huge. So we all just packed a lunch, right? We planned for that day. We assigned, okay, you're in charge of finding the article or articles, right? We all read them. We all then had a sort of a discussion about them. And I would say that was super helpful. So that again allows us to have or to review some of that evidence-based practice, or at least get an idea of what evidence is out there. I think another solution was having um, another therapist that I could ask questions to, right? Or when I was really having a hard time with the whole Days of Our Lives being on at 11:30 in the morning, right? And I wanted to get my AM self-care routine, like I was behind schedule and I didn't get to this patient's room before Days of Our Lives and they really wanted to watch that. Um, how could I communicate with the client without making them angry? Um, and so that I could get my treatment session in before lunch, right? Or before we had a discharge planning meeting, which I'll talk about that later on. And so it was really nice to get some help navigating that at first. Um, I know I had one of my fieldwork educators, I kept saying, I am really struggling with this. And then she was able to kind of model that for me so that I could be a little bit more assertive with that. And it's not always easy. So, some of the conditions that we commonly see in acute care, they could be patients with a single episode condition. And so when I worked in acute care, we had 2 orthopedic surgeons. And so very commonly we had hip replacements, we had knee replacements, we had a hip after a fracture, right? We had femur fractures. We had a patient that would just come in and they just had one single episode kind of a condition. Okay. Those were rewarding. I feel like we were able to really get in there and assess what is this patient's current level of function? Can we teach them different ways um, to do what they have to do so they can go home quicker? Or, right, do they need a little bit more time of healing, a little bit more education and practice? And so then we might recommend that they go to a transitional care or long-term care for more rehab. Excuse me. Another type of diagnosis is maybe it's an acute phase of a longer term problem or a longer term rehabilitation. Sorry, I got a tickle in my throat. So this could be typically like a stroke, right? They're going to need a long rehabilitation process, or a traumatic brain injury, a spinal cord injury. And so this might be kind of a more severe type of diagnosis with a more questionable or longer term type of prognosis. Um, so we may just be doing things in acute care to help this patient get stabilized. It might look like perhaps some range of motion, right? We might do some very basic ADLs if we can, if that patient can tolerate them. We might do some general assessment of, can they sit at the edge of their bed? Do they have their balance? Um, do they have vision? Or do they have some inattention or neglect? So we might focus or we might get an idea for that. And eventually they may then be transferred out to a transitional care, long-term care, maybe a rehab hospital for that matter. And so we might just be seeing them for a short amount of time while they're getting medically stable. Um, we would sometimes see patients that are chronically ill, meaning that they have something chronic, but they're getting some type of an acute exacerbation. This might mean that they maybe have a chronic condition with their heart. Maybe they have chronic heart failure, right? Or congestive heart failure, which can be chronic. And now all of a sudden they're having more cardiac issues, right? Their blood pressure maybe isn't as regulated. Their heart rate is acting up. And so they may be coming into acute care so they can monitor their heart rate a little bit more, um, and sort of get their blood pressure more under control, those sorts of things. They might have an acute exacerbation with arthritis and have excruciating back pain. Okay. They may have all of a sudden uncontrolled diabetes, where maybe they're in and out of consciousness, right? Or maybe they've had syncope or they've passed out, or uh, they're having some of those blood sugar issues. And so they need to be in acute care, so that they can be monitored more closely, um, while the physician makes some of those changes to some of their medications. They may be in acute care too after surgery. And so some of them may have an orthoscopic surgery, right? They may go in through the shoulder. A lot of these orthoscopics, fortunately, are done as an outpatient basis. Um, some of them, if there are complications, you might find them in acute care. Back and neck were really common. So one of our orthopedic physicians would do some kyphoplasties on some older adults. They typically needed an overnight stay in the hospital or maybe a couple nights in the hospital. And so after that right after they're wheeled out of recovery and they're into acute care, right, that following day we might we'll give them a day to come to, become more alert, have their anesthesia wear off, and then it's usually PTOT, um, evaluate and assess for discharge planning, right? What's the most appropriate discharge plan? Can they do what they need to do in order to go home right away? Are they having more complications with pain? Do they need more assistance than what any caregiver can provide? And so are there other ways for them, other discharge places for them to go? Open heart surgeries. Okay. And so are heart surgeries, angioplasties, cabbages, all of those things too. You might find somebody in acute care. After cardiac surgeries, it seems to me like a lot of them would go to intensive care for a while. And then from intensive care, they would get a room into acute care. So that's kind of how it worked where I worked. Some of them can be admitted to acute care for diagnostic testing. Okay, so maybe, and it can be in kind of combination with any of these other kinds of diagnoses, but they may be admitted into acute care for observation, which then they might be doing an MRI of something, a CT scan, X-rays. Okay, they may be trying to get some back pain under control or neurological pain under control. And so they may be doing some IV medications or pain medications that just can't simply be done in an outpatient type of basis. So then that leads us to our common length of stay, right? And so in acute care, your common length of stay varies significantly, because it really is going to depend on what's being done, right? So if somebody has a traumatic brain injury, and there's a lot of swelling on the brain, and that person's blood pressure is out of whack, right? It's going to take them a long time to get them more medically stable. And so that person may end up staying in acute care much longer than, say, somebody who has back pain and they're doing IV pain medication, right? Or somebody who's younger who just had a hip replacement, okay, who's maybe in their 50s, had prior level of function, living independently, they might be able to go home after 2 days, maybe 3 days, okay, as opposed to somebody who is 98 years old who fell and broke their hip and has a hip pinning in place or an ORIF in place, right? They may be in acute care um, for maybe 4 days or 5 days or 6 days before then they get transferred to maybe skilled nursing. Okay. So it really is, that length of stay really is dependent on so many different factors. Um, a lot of times, though, that length of stay is relatively short. So in the facility where I worked, it was like that 3 day turnaround time was sort of the average length of stay. So again, it's average, right? We'd have a patient that would be in and out, or we'd have a patient, if they needed to be more medically stable, they needed to be there longer than that. Got a window that popped up here. Let's go back to OT evaluation. Let's see here. I went ahead too much. Here we go. So OT and acute care. Those are the diagnoses. So that brings us to our evaluation, okay, in acute care. And so in our evaluation, we absolutely need to find out what that patient needs to do in order to go home. Okay, what do they want to do? What is meaningful to them? Um, so the first thing we would do, even before we go into that hospital room, is going to be to do a chart review. Okay, so pull up their medical records, double check the physician orders, look for any precautions that that physician is recommending. There may be cardiac precautions, there may be surgical precautions, there may be medication precautions or blood pressure precautions or precautions about vital signs. Okay, so you're really looking for any precautions, contraindications. Somebody could be NPO, meaning you can't give them anything by mouth when you go in there. So really, really be diligent about, okay, what is this person? What's their diagnosis? What did the physician order? What are the precautions associated with that diagnosis? You'll be looking at their current medical history or past medical history as well. So do they have a history of prior surgeries? Do they have a history of falls? Do they have a history of chronic or of being readmitted to the hospital several times? Do they have other diagnoses, right? So maybe they're being seen in the hospital for a hip replacement, but they have a history of COPD, okay, or they have a history of cardiac arrest. Okay, so all of that is or diabetes mellitus, right? So all of that's super important. So we can get a good picture of that patient. It's helpful to see what the current vital signs are. Sometimes it's a, hey, Nurse Tavia, when's the last time you did your vital signs on room 203? Okay, can you tell me, is he stable enough for me to go in there and get him out of bed? So sometimes it's just simply having that conversation, right? Then hunting and pecking for it in a chart. I know that's helpful. Medications. I know this was challenging for me as an OT. I never took a pharmacology course. And so I didn't always understand or know what medications I was looking at. Um, so again, that's where I would say, hey, Nurse Tavia, right? Can you tell me about any medications? Do any of them cause dizziness? Do any of them cause anything that I should be worried about? And it was those really good nurses that helped me, right, understand. Um, oh, this person's on this, it may be affecting blood pressure, or this person's on this, it might be affecting. And then over time, like I learned what those medications were, right? And I was able to kind of then look for those in other patients' charts. And then I would know, oh, that's what this medication is for, or um, I got it. I think now too, back when I was in acute care, we couldn't have phones on us. It's kind of a whole infection control thing. But now with um, the use of computers and electronic medical records and those kinds of things, I think it might be very simple to do some searching on what is this medication, what are the side effects, those kinds of things. If the patients had any labs, this would be really important for us to check out also. Um, After a surgery, I typically would look for hemoglobin. And so we had sort of a department policy that if somebody's hemoglobin was less than 11 or less than 12, right, PTOT would defer a day and not get them out of bed, because chances are they would need a blood transfusion. And if we got them out of bed, they would likely pass out. And so we just sort of set that as a department policy. So we really looked for labs. Um, if we notice that somebody's electrolytes are off, or um, creatinine, bun, all of those kinds of blood tests and stuff, sometimes if they were way out of whack, that may cause the person to have issues with balance. Okay. And so that was really helpful to know or to check what some of those labs were, and if they had been drawn yet. Progress notes. So any physician that comes and does a check, sometimes they do their progress notes or they check their patient really, really, really early in the morning, right? Before I even get to work. And so sometimes it's helpful then to do that chart review every single day, right? Did the physician see them? What did they notice? Sometimes the social worker or the nurses will write progress notes too, and you'll kind of see where that patient is at for that given day. Social history. So sometimes if the social worker or case manager gets into the patient's room before we do, they're going to get a really thorough social history. And so this will tell us, does the patient have a significant other that they live with? Is that significant other able or willing to help, right, with any caregiving or any um, carryover at home? Sometimes they'll talk about the home setup, or talk about maybe adaptive devices that they may have. They may talk about, are they a current smoker? Do they smoke in the home? Are they a community driver? Do they drive to and from appointments? Do they have family support? Do they have a history of getting Meals on Wheels in the community? So you should get a good social history. As OTs, that's really important for us, right? To know that context, that personal context um, of what support systems they have in place. Um, if sometimes that social worker case manager isn't there when I'm there. And so um, I might ask a lot of those social history questions as part of my occupational profile. Again, we do an occupational profile. We're interviewing our client again to try and find out, what was your prior level of function? Were you completely independent? Did you get help? What was your role? What was your spouse's role? Who does the laundry? Who does the cooking? Who does the cleaning? What's your plan while you're laid up and healing for doing laundry if that was your primary role? Okay. So you're asking them these particular questions. You're asking them, what is your home setup like? What is your shower setup like? Do you step over a bathtub? Do you just walk into a shower? Do you have a bath chair? Do you have grab bars in there? Where are the grab bars? Are you sure it's not one of those washcloth cloth things? Or is it really sunken into the wall studs? Do you know for sure? You don't know for sure? Do you have a family member who could maybe take a picture of that and bring it here and page me, right? And I'll come take a look at that so I know exactly where it's at. Why is that so important? Because that patient's going to have to bathe when they go home, okay, if that's not contraindicated. And if I can replicate or simulate what environment that they're used to at home, they'll be much more successful when they go home if we can practice and simulate with a similar type of setup in the hospital, okay? So that's why I get really, really thorough in understanding what their home setup is like, what they're responsible for, and what that prior level of function was like. Whose roles were what? Okay. Um, do you have a plan for meal prep if you were to go home? Okay, what's your goal? Is your goal to go home right away, or is your goal going to be to go to skilled nursing for rehab after a few days here in acute care? Okay, what's your expectation? Okay, we'll do what we can to help you get there. Okay, so that's kind of what my occupational profile looked like in acute care. That helped me understand not only what that client wanted to do, did they want to work on um, cooking or meal management, right? Or were there other things that needed to take priority, like toileting, dressing, those kinds of things? When we get to our analysis of occupational performance, this is where we have a couple options here, okay? What I primarily did in my evaluation was observation of those basic activities of daily living, okay? When I say basic activities of daily living, I mean, can they get out of bed? Can they get dressed? Socks, shoes, pants, shirt, okay? Can they get to and from the bathroom? Can they do their toileting hygiene? Can they bathe themselves? Okay, so I'm looking at kind of those main areas. Okay, grooming, hygiene, dressing, bathing, toileting. Okay, if we need to look at cooking or meal prep or those kinds of things, we might be able to look at that or have them simulate something like that. I'm observing them and I'm seeing what level of assist are they with that, and I'm sort of guiding them. Okay, or I'm sort of interpreting them. Um, Again, understanding that in acute care, if they have somebody at home who's going to be providing meals for them, or the case manager could be doing meals on wheels and helping them get into that community resource, okay, then I'm not going to focus necessarily on that. I'm going to really look at those getting them to the bathroom, okay? Based on their precautions, based on their surgical precautions or any precautions they may have, I may actually be bringing adaptive devices into their hospital room and practicing with those devices. I might make the recommendation that they have those devices prior to discharge home, okay, so that they can follow those surgical precautions. So then I'm observing them, right, as part of my analysis of occupational performance. Where that becomes an issue, and where I think us as OTs have gotten a lot of criticism, is my min assist might mean your max assist. Okay. And so when we're looking at observing, right, and not everybody does section GG in acute care, right? But are there ways that we can do more standardized assessment tools that really help us hone in and are more objective? The problem where I ran into using standardized assessment tools are time right? I think going from room to room, what kind of equipment do I need to bring with me from room to room when I just have my pockets, right? What do I need to be schlepping from here to there? All those kinds of things. Um, so your chapter 4 OT and acute care book has a tremendous amount of OT eval or assessment tools that are geared for being simpler to do in an acute care setting, which is huge. Okay. And so just a couple examples, and I like how the textbook sort of organizes. You have occupation-based assessments, right? And then you have more performance component assessments. Okay. So again, you can do that observation and have that level of assist as a means to analyze occupational performance. To me, that makes sense. But again, it also makes sense that my observation and level of assist might be different than somebody else's. And that, that's not okay. Um, the standardized assessment tool that I know many of you have had in class already and is occupation based or occupation focused is the Barthel, right? The Barthel activity of daily living scales, right? And so that specifically has us identify what level of assist they are with some of those basic activities of daily living. That would be super helpful, right, in an acute care setting. And you could also then observe them do those basic activities of daily living while then scoring the Barthel so you have that objective standard score. Okay, it's going to bring more validity to how valid and accurate your evaluation findings are in that acute care setting. That's one of 100 different examples that are in that textbook. But one, since I know I teach OT evaluation, that's one of those assessment tools that we covered in that particular course. And I believe Dr. Kitzenberg had that one covered as well. We specifically had that one in there. When you look at the way the textbook is and looks at performance component assessments, okay, this is helpful because if I just or I just do the Barthel, right, and I'm like they're mod assist for dressing, right, or they're mod assist for toileting, or why are they mod assist? Is it because of their weight bearing status? Is it because of their cognition? Is it because of their balance? And so when you look at some of the performance component assessment tools, right, you have the mini mental, you have the slums, right, for cognition. There's many other ones that are in there as well. But again, those are probably ones you might have heard of before. There is the Tenetti or the Berg balance scales, right, to look at balance. Again, I didn't have to do a lot of those because my PT counterparts were oftentimes doing those. But then again, that's where we needed to really connect and say, hey, they were mod assist, right, for a transfer. And the physical therapist is like, yeah, I get that because they actually scored this on the Berg balance or this on the Tenetti balance. And so so you can kind of, that interdisciplinary communication is super helpful. So again, there's room for standardized assessment tools in your practice. There are some that are occupation focused that I think are super helpful. There are some also that are performance components, and it's nice to have a variety of both of them. Okay. So there is a sample evaluation form in your OT acute care textbook, and I do have a sample of that. We'll kind of take a look at that towards the end here of my lecture. I think other analysis of occupational performance, I teach musculoskeletal conditions here for Bismarck and Fargo. And so another thing that we do that we would consider standardized assessment, it might just be a quick upper extremity range of motion and quick manual muscle test, right? And we might be observing what that is. And then our analysis of occupational performance is upper extremity strength impacting their ability to weight bear with their arms, right? And use of a front wheeled walker when they are non-weight bearing on that right lower extremity. If they're a manual muscle test of a 2 out of 5 on their right shoulder, right? I would venture to guess that isn't enough strength for them to be non-weight bearing and to support their weight on one lower extremity. And so again, that could be another standardized assessment tool that we give, but then we need to thoroughly explain how and why that's affecting occupational performance. So one of the big roles that we have as OTs in the acute care setting is helping identify appropriate discharge planning. So every day, every single day, we had a discharge planning meeting that occurred on acute care. Again, a lot of our clients might be there for a day, they might be there for 2 days, 3 days, and we're constantly as a team with nurses, physical therapists, speech therapists, and the social worker. Sometimes the physician comes in, um, sometimes family will come in, right? And they'll talk about their patient or we'll talk about the patient. Where are they at functionally? Um, where do we think that they'll be able to function at tomorrow? Um, where is the most likely place they're going to be discharged to? And so it's a team decision typically. And OT is so very important because we can specifically say, hey, they are max assist to get out of bed. They are max assist to stand up from the toilet. They're unable to do their toileting hygiene. And so, like, they're not ready to go home. Okay. So then it becomes a question for the acute care case manager then to say, oh, then, you know, I mean, they can't stay in acute care forever. So we have to look at, and if they can't do that, they can't go home. So we probably need to be looking at another placement for them, whether it's skilled nursing, whether it's um, transitional care or swing bed, something along those lines. And so, who better to report what level of assist or what that patient can do for themselves with what it is that they need to go home than OT? Um, Sometimes it's, you know what? Yep, Mr. Bob was able to get out of bed with probably some minimal cueing, verbal cueing, right? He was able to follow that weight bearing precaution. We gave him a raised toilet seat with a toilet frame. So he's able to follow that weight bearing precaution. He was able to complete his toileting hygiene. He was able to complete his bathing. And so if he has this equipment for him to go home, right? I think by tomorrow he'd be ready to go home. And I think that was very, very intimidating for me as an OT, right? To make that call. Oh my gosh, I was so worried. Like, what if I say he goes home and falls, right? But we have that very objective data then, right? Of where is he functionally at? We can also use this as a time to problem solve with PT, right? As a problem solve with speech, to problem solve with nursing, to problem solve with case managers, maybe even to problem solve with family if family's available, right? If family's not there during the meeting, a lot of times that case manager is visiting with the family. Um, so on the slide here, I have autonomy promotion versus risk avoidance. And so when you look at this, right, and I think the big issue as OTs is we want to promote as much independence and autonomy that we can for our patients. Okay, so yeah, send them home, let them be independent. But there's also the perspective of What if they fall, right? What are the risks? We want to avoid any and all risks whatsoever. So then there's the risk avoidance, and sometimes, right, they kind of are arm wrestling one another. Okay. And so it kind of comes down sometimes with discharge planning, it kind of comes down to a couple ethical principles of at what point is the person able to determine for themselves, right, their level of independence, um, versus our responsibility of beneficence and of doing no harm, right? And what's the greater good? And so this is where, again, sometimes these meetings might get a little, I wouldn't say heated, but where maybe team members might have different perspectives. Okay. So that's why we like to bring up, right, all of the stakeholders, all of the therapies that are involved, nursing that's involved, and sort of identify family and sort of identify where is this person currently at? Are they safe to go home? Are they safe to go home with particular supports in place, right? Or do they need to go for more rehab? Or do they need to go to long-term care? Um, and so sometimes there is conflict, right? Sometimes there's conflict because the person doesn't want to go to a nursing home, right? Or they just want to go home. They just want to be left alone. And so sometimes there is that conflict. That's where sometimes those standardized assessments really come into play, is they're even more objective, right? And we can use those as evidence to support perhaps our recommendation of um, long-term care or another type of discharge plan. So in our team meeting, what we bring to the table, right, is we can bring where that client is at with their functioning, right? We can ask the team, what's the realistic ability of this person to sort of fill in the gaps of where they can't perform independently? Is their caregiver ability? Is there maybe home health care, right? Is there other things in the community, other services in the community that could help fill those gaps of where that person is lacking full independence? How accessible is the home? And so sometimes too, we talk about, or OT, we're really good about talking about what adaptive equipment they are reporting that they have, what adaptive equipment we're using in our treatment sessions that helps them be more independent and safe. And this is where that case manager can really bridge that communication between family, right? Or say, hey, this person's ready to be discharged home, but we're not going to discharge until you get the toilet raiser or riser, grab bars, and those sort of things in place. Okay. Any financial resources. And so a lot of times with financial resources, that case manager is super helpful. Typically, I know sometimes as an OT, there would be people that would need to be discharged. We were looking at discharging them home with like maybe a transfer bath bench, right? Well, they couldn't afford a transfer bath bench. And so are there other areas or other things in the community? I know there are some therapists who would go around to garage sales, right, and start collecting things like transfer bath benches, bath chairs, those kinds of things, and just store them. And then they would just magically be there if that person needed it. I know there were other community agencies that sort of had adaptive devices that could be used as loaners, right, or as a loan. And sometimes they're there, sometimes they're out, those kinds of things. So um, again, it's kind of a partnership with case managers, but us as OTs, we really kind of looked at that as well. Cognitive capacity to make a thoughtful analysis on one's own ability. And so OT, we're looking at cognition, right? We may do standardized assessment, of course. We might also just do some simple screenings, or it might just be some observations we make during their self-care, right? Are they able to cognitively follow their weight-bearing precautions? Um, I know speech therapy also does a lot of cognitive evaluations as well. And so, um, cognition, again, it might be helpful to have that standardized assessment. In acute care, sometimes it's hard to sort of prioritize that. And if everybody's seeing that there's cognitive issues, right, and that's affecting safety with transfers or following weight-bearing precautions or surgical precautions or taking medications, those kinds of things, that's usually brought up with the team. And that certainly impacts then where that person's able to be discharged to. So OT's role in discharge planning, present options that minimize risk. Okay. And so this is where, we really were able to rise to the occasion. PT sometimes would be like, oh, they were able to walk 20 feet um, with the front wheel walker. So we're discharging them. Right. And I'm thinking, okay, well, they only have a tub shower combination, and they don't have the weight bearing status to step over the bathtub. And so, you know, if they're willing to get a transfer bath bench, we can work on that, right? Because then that would allow them to sit down and not have to step over the tub. Um, and so again, it's usually like as an OT, for me, it was coming up with options and saying, well, they can get themselves dressed with the use of adaptive equipment or with the reacher, with the sock aid, right? Or it might be me saying, well, the caregiver is saying that they're going to do their TED hose stockings. So, but we're still recommending a reacher so that they can get their pants on and those kinds of things. Uh, so a lot of times it's presenting options. It might be adaptive devices or adaptive equipment, but we really need to make sure that the team, that we're providing that rationale to the team, to the family members, very clear documentation, communication with other disciplines and family. Um, I know sometimes with nursing, they're also taking patients to and from the bathroom. And so it's sort of helpful to make sure, hey, if we change something in their bathroom, or if we're trying to educate the patient on, using this grab bar on the left-hand side, because we know at their home they have a grab bar on the left-hand side, that's something we might want to communicate with nurses, so that patient's getting that extra practice with nursing, okay? Because that's going to help their independence. Consider prior level of function compared to what their current level of function is, okay? Also, then that helps us identify what the impact is of their current illness. So if their prior level of function was maximum assist with lower extremity dressing, we probably don't want to use our limited time with that patient to work on lower extremity dressing, right? We probably want to work on other things where we may have more impact on increasing independence. We're going to consider their home environment. How many stairs do they have to get into their home? Where is their bathroom at? Where is their bedroom at in relation to their bathroom? How do they navigate around their home? What's their motivation to engage in life? What's their motivation to be independent with certain activities of daily living? What was their prior IEDL and basic IEDL or basic activities of daily living status? Okay, so what could they do for themselves? Are they a fall risk? Okay, what kind of supports do they have in place? And so those are all things that we can talk about in our discharge planning meeting. and also get information from other team members as well as family members. Okay. So if somebody is not motivated to be independent getting to and from the bathroom, um, you know, and they're not interested in being independent dressing themselves, they don't want to engage in therapy. We're sometimes asked to identify what their rehab potential is. And if somebody's lacking that motivation or they have a high level of care at a prior level of function or a high level of assist with that prior level of function, their rehab potential um, is not the best. Right now, I hate to use the word poor. Rehab potential is poor. I hate to use that, but sometimes, if we're looking at identifying rehab potential, um, and it is less than ideal, right? We probably wouldn't recommend a discharge placement of home, right? If they're not motivated to work on toileting, if they're not motivated to work on dressing, if they don't have a good support system, um, that would indicate rehab potential. On a lot of forms, we're asked to identify what that client's rehab potential is. Um, Again, you might use different terms. I've seen poor used, which I very didn't use that a whole lot. I've seen fair, I've used good, I've seen excellent. So your facility might have different ways for you to report what that rehab potential is. And it really goes into home or really goes into what's their home setup like, what's their motivation, what's their prior level of function, what's their health status, okay, what's their prognosis for their diagnosis, what's their support system. So all of those things should be taken into account, and based on their rehab potential, that should help you identify or help the team identify the most appropriate discharge place. So, what are some of those discharge places? Okay, well, they could be discharged to a facility that has hospice or home with hospice care. And so that's typically for people who are terminally ill that have less than 6 months to live. And typically they're just on comfort measures, if you will. They could be discharged to a skilled nursing facility. So this might be families unable to care for them at home. They're always going to have the availability to get assistance with activities of daily living, such as dressing, bathing, grooming, hygiene, feeding if needed. There are places called long-term acute care facilities. This is where typically they're too sick and need more medical support than just a regular acute care setting. Um, it might be because they're having specific protocols for wound care. They might be getting 2 or more types of IV antibiotics. They might be on a ventilator and expected to be on a ventilator for a long period of time. The facility I worked didn't have long-term acute care. Um, so we just had a ICU, acute care, and then a transitional care, and then we had some community nursing homes available also. Home health. This is typically multidisciplinary. Typically, OT, speech aids are not standalone services, so they must have some type of physical therapy or skilled nursing ordered, or at least in the beginning. And so, you can't have a home health CNA go in to provide basic activities of daily living unless there's some kind of skilled nurse that's going in there for wound care, um, uh, antibiotics, um, real specific nursing types of things. Subacute rehab is usually once they go into acute care, uh, they might have to stay in acute care for to at least 2 days. And on that third day, they can transition to subacute. Okay. And so typically I've heard subacute referred to as transitional care, swing bed, something like that. And so they're able to progress. Um, it's typically there for therapies. Typically, they're slower progress. They may need a little more time. They may be more medically fragile. Um, Typically, they get less than 3 hours of therapy per day. Again, I'm thinking of transitional care in the facility where I worked was very similar to long-term care. Um, Older adults, right, need a little more time for rehab because maybe they just aren't strong enough. They can't tolerate the activity to follow their weight-bearing precautions. If we can keep them in therapy a little bit longer, give them more practice, give them more supports, those kinds of things, then eventually we can progress them to home. Um, Inpatient rehab must require 24 hours nursing care. And now inpatient rehab, right, that's where they really need to tolerate at least 3 hours of therapy a day. And again, there are certain qualifications to qualify specifically for inpatient rehab. There are things called day treatment programs where they provide some kind of integrated rehab. Typically, they're managed at home, but then they can come into some kind of a facility where they're getting some kind of treatment throughout the day. And again, this can be more interdisciplinary. So there's many different disciplines that are working with those patients as they're coming into the facility. Kind of similar to outpatient. Outpatient facilities, the patient is medically stable. They can be at home. Typically, in outpatient, we're providing them a lot of education and then understanding that they're implementing those strategies at home, right? So they can continue to make improvements. So this is where we're going to kind of transition to more of that intensive care unit. Get caught up here. Intensive care, intensive care is providing the most medically complex care for critically ill patients in the hospital. So they're very medically fragile. Okay. Um, it's a very high demanding stage of recovery, both psychologically and physically. Um, we're seeing more and more OTs, PTs getting involved in rehab or with rehab approaches in ICU. We're seeing that if we're starting to move patients more much earlier on, um, there tends to be a shorter length of stay overall in the hospital, as opposed to staying in ICU for a week then moving out to the acute care floor, right? If we can get involved earlier on, there tends to be a much shorter length of stay in the hospital. If we can get involved in ICU earlier on, we're showing that there's more discharges home right from ICU or right from acute care rather than from like a rehab hospital. And so if we can get involved sooner, right, their discharge home is more frequent. If we can get people moving a little bit sooner, they typically require fewer ventilation days. If we can get them moving sooner, there's fewer hospital complications. And when I say hospital complications, what typically happens is when somebody is lying on their back for long periods of time, like say a week or so, they're more prone to get skin integrity issues, skin breakdown, pressure sores. They're more apt to have issues relating to pneumonia or acquiring pneumonia. Um, they're more apt to have infection. And so there's many, many, many bad things that can happen when people are in the hospital for longer periods of time. And overall, people, if we can get them moving sooner in the ICU, they have improved functional outcomes, meaning that they can do more for themselves much sooner than if they were to stay in recovery in ICU with no therapies. Okay. So typically, although there are lots of benefits, um, and the low risk that therapies provide, meaning that there really isn't a great risk by getting therapy involved sooner. We don't, or hospitals don't always think to offer OT right away. Okay. I think they don't always know what we're capable of doing, or they might say, hey, this person's on a bedside commode, and so there's no need for OT. Well, we could still be working on that transfer. We could still be working on dressing. We could still be working on basic grooming hygiene types of things to get that person more engaged, more alert, oriented to task. There's lots of things that we could be doing again to help with these early stages. Vital signs. So you're going to see lots of different vital signs in ICU. I think this is probably the most intimidating part, or at least for me it was, where you have these monitors, you have beeping that's going on, what all the numbers mean, those sort of things. And so my greatest tip of advice to you is to make sure that you talk with nursing before you go into a patient's room, right? You tell them what your plan is. You ask about their vital sign ranges. You ask them, right? The nurses in the ICU are the patient's angels, essentially. And um, some of the nurses, I know I joke about Krista, I joke about Tavia, um, but they were so involved in their patient care, and they were so invested in them doing so well in the ICU and getting better, that they didn't want anybody coming in and disrupting that. And so it's best if you can approach that from a collaborative standpoint and really learn from one another. I've learned so much from the nurses in ICU. Um, a lot of the common things that you'll see: urinals, hats. So there might be little things on the toilets, right? Or those clear plastic urinal things, right? Very handy for men to just grab it and stay in bed and just kind of put their parts in it and use the bathroom that way. Um, I kind of have an issue when I see that there's food on their nightstand, right, or their tray table, and then they have the urinal right next to their food. I kind of lose it a little bit with that. I think that's gross. Telemetry kind of looks like some sci-fi kind of thing where there's like a battery pack, and then there's all different kinds of colored tubes and or little tubes, right? And all of those tubes are connected on a snap that's strategically placed on the patient's chest, side, back, right? And they're being monitored of those vital signs, their heart rate, all of those things 24/7. Um, I'm not going to go into, like, we have blood pressure, heart rate, oxygen saturations, um, electrocardiograms, all of those sorts of things. There might be arterial line blood pressure. There might be pulmonary artery pressure. There might be things connected to their head that are measuring intracranial pressure, encephalogram or electroencephalogram leads. So they're monitoring brain activity as well. And so it's helpful, right, to know exactly what your patient is hooked up to, what it's monitoring. And if you are looking at moving them around, one, do you have the leads to do so? Does the tubes and do the lines all move, right? Or not, right? Do you have to unhook anything to get that patient to engage in therapy? And if so, right, make sure that that nurse is involved in helping you with that. Let's see here. Here are some of the normal signs. We all know blood pressure, right? Systolic is 90. Diastolic is 60 to 80 millimeters of mercury. So we're looking at 120 over 80. I believe the American Heart Academy now says hypertension is less, or blood pressure is less than 120 over less than 180, or less than 80. Sorry. Um, I don't think I've ever seen anybody's blood pressure be 120 over 80 in ICU. They're typically like much higher than that. That's why they're there in ICU, or they're much lower than that. That's why they're in ICU. SpO2 normal range is 95 to 100% on, they may be on oxygen. Some people's normal is 90, right? Or typically, right, we don't panic unless it starts to dip below 90. And so as we're doing activity, we might be monitoring their O2 saturations and their heart rate, right? We might be looking at that. And if it dips below 90, we might be having the patient rest and sort of say, okay, take some deep breaths through your nose, out through your mouth, right? So we may be having to monitor some of these vital signs um, as well. More of the invasive, these mean that they're usually indwelling. You might have Foley catheters draining urine. You might have rectal tubes that are draining bowel. Um, there might be central lines for cardiac output or external ventricular drains measuring intracranial pressure. So you might have little ports or little needles, right, that are in certain veins. Those sorts of things, they may be in there for various reasons. Here are some of the examples: central venous pressure, pulmonary artery wedge pressure, cardiac index. Um, and so just know that pulmonary artery catheters, right, they could be measuring many different things. What I want you to know from this lecture is that um, if there are indwelling catheters, that just have caution right when you're getting a patient up. In ICU, they'll likely be wearing a hospital gown, right? It's helpful to know and just to take a little bit of time to find out where some of these tubes and lines are at and sort of gauge, so you're not yanking on anything or pulling anything out, because that can be very painful. Again, asking nursing, okay, if I move this patient, my doctor's order is to start working on therapy. If I move this patient, are there any of these alarms that you want me to be aware of or to call you ASAP? Or do you feel like they've been pretty stable for a while? It's nice to have that relationship with those nurses. In ICU, it's not uncommon for us to really look at or see patients that have activity intolerance. Okay, so they just can't tolerate much activity at all. They're very, very, very sick. Warning signs that they're not tolerating the activity or the treatment that you're doing might be that you notice they're having increase in anxiety or they appear anxious. Okay, maybe they're saying, hey, I'm having a lot more pain, or maybe they're showing signs and symptoms of discomfort, or they're saying, this isn't comfortable, I just really want to lay back down. Maybe they're short of breath, okay? Or you notice that they're really becoming more short of breath. They might complain of lightheadedness. They might complain that all of a sudden, oh my gosh, I just became really, really weak. My legs feel like they're 500 pounds apiece. I just really need to sit down all of a sudden. I can't do anymore. Okay, so you might notice that change, right? A sudden change. Also, if there's any changes in the patient's perception of their body, right? Like the room is spinning, okay? Or I feel like I'm falling forward, or I feel like I'm leaning backwards, right? When really they're just laying there. So any of those things could be warning signs that they need a rest, or that you need to check some vital signs, okay, or call that nurse. Now, contraindications, okay, meaning that therapy would not be advised, or you need to stop and call somebody ASAP, is if there's an acute change in their mental status. So you can measure that if they have intracranial pressure of 20 milligrams of mercury, that means there's too much pressure that's happening in their brain. So we need to stop the activity. If all of a sudden they become really confused, where really they weren't confused before, that would mean that we need to get somebody in there right away. They could be having a stroke. Okay. If there's any new cardiac arrhythmias or ischemias, so if you're monitoring that heart rate, right, and then that heart rate is all over the place, or some of those heart rate monitors going off, right, that's something where we need to really make sure we're noticing or contacting the nurse. When we're measuring respirations, right, a typical respiration is 10 to 12 at rest. Sometimes people who have really poor activity tolerance, you might see them get up to 20 breaths per minute, right? And so if they're getting up to 35 to 40, that means that we need to have them stop, right? If their O2 sats are less than 88% for over a minute, so you're asking them breathe in through your nose, out through your mouth, in through your nose, and it keeps dropping, we need to stop doing what we're doing. If a person all of a sudden has changes in vision or is experiencing dizziness, we should stop. If their heart rate increases to 130 beats per minute or 20% above their resting heart rate, that's also an indication that we need to stop. If all of a sudden they turn gray and they start sweating, that means they may be having acute diaphoresis. And so we need to stop what we're doing and again, notify somebody. And we likely wouldn't be continuing our therapy at that time. We might be coming back or checking in on them later. So common conditions that we see in the ICU, they are going to be cardiac precautions or cardiac conditions. Okay, so issues with heart rate, issues with arrhythmias, heart attack, those kinds of things. They may be on cardiac rehab, like different phases, right? They may be on phase 1 cardiac rehab. They may have just come out of open heart surgery. There could be pulmonary conditions, meaning that they may be on ventilators. There may be there for post-op management. So maybe there are big incisions, right, that the nurses are taking care of. They're doing wound management, incision stuff. Maybe they are there after an operation because their heart is weak, right? Or they had some surgical complications. A common condition too is when somebody does have some kind of major infection that starts moving throughout their body called sepsis. Okay, people can die because of sepsis. And so they're usually there in ICU with some really hardcore antibiotics. Um, if somebody's had a neurological condition like a traumatic brain injury, a stroke, something along those lines, a spinal cord injury, they may be there in ICU right away to just sort of monitor everything. If somebody's at risk for a vasospasm or a spasm in a central blood vessel, they may have precautions to maintain their blood pressure. And so they may be there in ICU hooked up to telemetry, right? Really making sure that they're monitoring that heart. If somebody's at risk for seizure. So again, if they have traumatic brain injury, they may be there for close monitoring for seizure activity or brain bleeds. If you suspect somebody has had a seizure, right, make sure that you're transferring them to the bed and you're notifying the nurse immediately that you're suspecting a seizure. If there's high risk of secondary injury, So maybe there's damage to brain structures after an injury, such as if they're having a lot of brain swelling, right? Or if they're at risk for seizures, or if their intracranial pressure may increase, if they're at really close risk of having a stroke, all of those things, right? They may be in ICU right away with. So those are really common types of conditions. Um, So, how do we evaluate for these really complicated conditions? Sometimes a full general evaluation might not be possible because of all of the tubes and lines that are connected, right? And so it might not be possible for you to get them out of bed, do a toilet transfer, those kinds of things. You could simply state in your evaluation if something wasn't attempted because of their connection to certain types of tubes and lines. They may have limitations, or maybe a full evaluation isn't recommended because they're on activity precautions, right? And so maybe you're just evaluating basic grooming hygiene, okay? Or maybe you're just evaluating self feeding. So talk about what you are able to evaluate, maybe what you're not able to evaluate because of their medical stability, maybe their cognitive status. So if they're confused, if they're not able to follow directions, if they're not alert, okay, there might be certain things that you're not able to evaluate. So you should document all of the tubes and lines, medical devices, um, and then that will help explain what you did not evaluate, why you didn't evaluate. Your chart review for ICU is absolutely imperative, and it's imperative that you understand that chart. I had very, very helpful nurses when I was first starting out that really helped walk me through, and therapists as well that walked me through the importance and significance of different conditions, medications, those sorts of things. So when I saw in your acute care book that there's an ICU systematic approach to chart review, I thought, wow, that would have been so helpful. Um, a lot of times I had nurses that would help me out, right? Or they would tell me, hey, make sure you do vital signs before you start activity. Let us know what they are. And then when you're done, go ahead and run those again and let us know. And so, or I've had some nurses that are like, yeah, let me just come in there and let me see their vital signs. Let me see where they're at. So sometimes the nurses would go in there and do the vital signs. Um, a lot of times they might hook them up to a blood pressure cuff. That blood pressure cuff may automatically go every so many minutes, right? And so they may say, "Oh, let's just unhook that," right? And then they're like, "Oh, we'll just plug it in at 3 o'clock, and then you know that'll give you 15 minutes, and then you can finish your other 15 minutes, and then we'll test it again." And so again, I really had the nurses lead, and I really, really respected them um, with what it is that we were doing. OT evaluation in ICU, it's really important for us to even look at cognition, right? And a lot of times there's, people might just have had a stroke and they may not be alert. And so you can document that, right? You can say, hey, their cognition, they're not alert right now. They're not oriented. Um, Maybe when they become more alert, you might ask them, do you know where you're at right now? Do you know your name? Do you know what day it is? So you might start off very, very simple with your ICU evaluations. You might be looking at passive range of motion if they can't do active range of motion. Okay. You might do very basic ADLs, like can they bring a washcloth to their face? Can they bring a towel to their face? Can they wipe their hands? Can they bring a toothbrush to their teeth? Okay. Can they bring a spoon to their mouth? Can they drink? Again, if they just had a stroke, they might be NPO. So that's something to be aware of. Pain, right? Pain is really important. What's your pain level right now? Okay. We're going to move a little bit. Does that affect your pain? What's your pain level now? Okay, so we can constantly be using that pain scale on a 0 to 10 scale during our evaluations too. That can be really important. So goals and treatments. So what does that look like in OT for ICU? Probably just focusing on small improvements, right? So they may not necessarily become independent, right? But maybe they can tolerate sitting at their edge of bed in preparation for grooming hygiene. So, we might be doing some starting with changes in position. I'm jumping ahead here, work on activity tolerance, right? So can they sit at the edge of the bed? Can we look at their O2 saturations and are they maintaining that 90% or higher by sitting at the edge of the bed? Okay, can we work on that would be focusing on improvement, right? We might be looking on components of tasks. So can they complete a bed to chair transfer in preparation for toileting, right? Can they complete a sit to stand transfer in preparation for toileting, especially if they're hooked up to all the tubes and lines, right? Um, it might not be appropriate yet to start with toileting. Um, can they put on gripper socks? Okay, gripper socks, a lot of times in ICUs, they might just have access to hospital gown. Gripper socks, maybe that's all you start with. Cognition, right? Now can they say their name? Right? Do they know where they're at? Can you do some cognitive things with them to give them more awareness of where they're at? I'm kind of jumping around a lot here, but goals with vital signs with task performance. So again, can you have them maybe start with sitting at the edge of the bed by looking at O2 saturations, right? Maybe you have, can they get to the sink or can they stand and brush their teeth at the sink? With blood pressure staying within so many millimeters of mercury, okay? Or with their heart rate staying between these ranges. And so you can write goals that are measured by helping maintain within those vital signs, okay, with a specific task. You can consider a goal for orthostatic stress tolerance during activity. So really looking at that blood pressure, okay? Or can they maintain alertness? Can they follow direction for a basic grooming hygiene, such as can they sustain their mouth staying open? Can they stay alert enough for their teeth to be brushed? So again, our tasks, our goals, our treatments might just be focusing on those very small, minute improvements. I think I've talked about collaboration and communication with nurses and other professionals. I think sometimes too, what was really helpful is in ICU, our facility really recommended that both PT and OT go in at the same time and do co-treatments. Okay, and we had protocols and stuff for following that. But the reason being is a lot of these patients are so sick, they don't tolerate a lot of activity. And so if I want to see how they're getting out of bed and PT wants to see how they're getting out of bed, if we can do that one time, okay, at the same time, we're saving that patient a little bit of activity. We're both seeing the same things. We're able to collaborate together. We're able to say, hey, how much assist do you think they needed, right? What are you going to focus on now with your treatments? Here's what I'm going to focus on with my treatments. If they're going to focus on sit to stand, right? I'm not going to focus on that for toileting. I might focus on maybe some upper extremity hygiene types of things or cognition. Some of our initial treatments might simply be active range of motion. Okay, it might be looking at how active range of motion affects their orthostatic stress or their blood pressure. If they just had a stroke, right, it might be passive range of motion. It might be active assisted range of motion. And again, seeing how they're tolerating that by assessing and monitoring their vital signs. We might be looking at what level of assist they're able to do a very basic activity of daily living. Okay, might be toothbrushing, it might be bringing their hands to their face for face washing. We might progress to supine to sitting to the edge of the bed. We might progress from edge of bed to chair. We might progress from chair to standing at the sink or sitting at the sink to standing at the sink. So there's lots of ways we can grade activity um, to help our patients. Something to keep in mind when in ICU, a lot of times our treatments require pre-intervention preparation, which just means we need to organize the environment. Okay, so if the patient is on a ventilator and they're on their right side and their sink is on the left side of them, okay, is there anything we need to maneuver or change or get help in repositioning the patient? Anything we can set up or move with their tubes or lines is anything that can be removed from their tubes or lines to help us. And so sometimes it takes a while disconnecting things, right? Or reconnecting things when we're done, moving IV poles, um, getting wheelchairs, getting oxygen tanks, right? All of those things take time. Um, Monitoring vital signs to determine the need for rest breaks. And so your initial treatment, maybe you're just counting rest breaks, right? While you're monitoring vital signs. I think you can sort of anticipate the need for a lot of rest breaks. Um, and again, I talked about this already. Our initial treatments or initial evaluations, it's sometimes helpful if you can co-treat or do a co-treat with more than one profession per visit. Again, they may only be alert for 20 minutes a day. And so if both PT and OT are there to see the patient, can we find out when they're alert and can we both be there at the same time so we can both have the opportunity to work with our patients? So basically, I get a lot of feedback from students just saying how intimidating ICU is, how scary acute care is. There's smells, right? There's tubes, there's lines, there's blood, there's urine, there's feces, there's the smell of bleach. It can be there's alarms going off. It can be very overstimulating. Um, if you're not used to that type of environment or that fast-paced kind of a situation or scenario, what I suggest you do is explore your videos that come on your USB drive in your OT acute care textbook. I think looking at videos, watching videos, um, there's complexities of ICU. There's videos on an ICU co-treatment. You can actually observe that with what resources you have. And so I strongly encourage you um, to be doing that. There's an acute care evaluation form, and I'm gonna, excuse me, I'm gonna see if I can't pull that up. This one. I guess I'll first, these are some of the other resources I posted for you. This is a discharge planning algorithm. And so it talks about basically, assessing for safety, assessing, do they have accessible environments, resources? And then it asks you, does the patient want to go home? Um, or does the patient require a comprehensive rehab program and skilled nursing care that can't be provided in the home? And so it's sort of that algorithm to help walk you through what might be an appropriate discharge plan. Like I said, in the community and facilities where I worked, or my community, we didn't have access to a lot of these. And so we didn't necessarily have some of these as options, but some of you guys might. Here's 9 ADL management in acute care. And so these are some really beneficial tips um, for you to consider when working in acute care. And so these are must reads. I think they're super helpful. I love this one. I get feedback from students that acute care is nerve-wracking for them, and so here's some very basic things or tips for success for you to go through. Um, and I love this approaches. Um, Stay calm. If you feel yourself getting stressed, sit down for a minute or two, breathe. Stress prevention is key. And so, just I think just recognize that um, this is a medical place, right? And it's an area of OT. Um, there's a lot of things happening at once, and just allow yourself some grace. It's okay if you're stressed out, right? It's okay if it's stressful, but you're gonna be fine. We find that OT evaluation. Where did it go? I'll just open it again. And so for the sake of time, I'd like you to spend some time just sort of looking at this evaluation form and sort of reflecting on what we talked about in lecture, um, maybe how you observe or how you could evaluate or assess. And I think I'll probably ask some kind of a discussion post or something to relate something about your readings and lecture to this evaluation form, and see what you notice. See if you can make some connections between anything that we talked about in the lecture compared to what you're actually seeing on this sample acute care form. All right, so I'll give you more clear directions on that um, shortly. All right.